Thank you for coming, everyone. I'm Olga Klinkova. I came from across the road from Moffitt Cancer Center. It's nice to see everyone. And I wanted to present a lecture today, giving you updates on the diagnosis and management of community-acquired pneumonia. If you have any questions, please feel free to interrupt and ask me. So first of all, we are all very excited about the arrival of this document. That was very well needed, and it was published just a couple of weeks ago in the American Journal of Respiratory and Critical Care Medicine. And these are the new guidelines on the diagnosis and treatment of adults with community-acquired pneumonia. So very important updates. So first, let's go over definitions really quickly. As you know, community-acquired pneumonia is defined as acute infection of pulmonary parenchyma that is acquired outside the healthcare settings or hospital settings. The nosocomial pneumonia is defined as a pneumonia which is acquired in the hospital settings, and it has two entities within it. Number one is a hospital-acquired pneumonia, which is defined as a pneumonia which is acquired 48 hours after admission. And number two is a ventilator-associated pneumonia that is defined as a pneumonia which is acquired once the patient's been intubated for more than 48 hours. And as we all know, the definition of healthcare-associated pneumonia has been removed from the updated documents, so this is no longer to use in your documentation. And just a couple of slides to refresh our memory on the microbiology and common pathogens for community-acquired pneumonia. As we know, we can divide them into three categories. There are typical bacterial pathogens, with strep pneumo being the most common one, followed by H. flu, Moraxella catarrhalis. You know, Staph aureus infections are on the rise, and some other ones listed in the table. There are atypical pathogens such as Legionella species, Mycoplasma pneumonia, and Chlamydia species, as well as various viral pathogens that are identified extremely commonly in the etiology of community-acquired pneumonia. So I just wanted to show you a couple of studies that studied the etiology of community-acquired pneumonia. So first one is it's a small study which was published in a Journal of Infection in 2013. And they evaluated 259 patients with a community-acquired pneumonia syndrome. And what they found is that 23% of the patients had a bacterial etiology, with, again, strep pneumo being the most common pathogen, followed by viral etiologies. They were identified in 16% of the patients. And as you can see, more than half of the patients did not have an identifiable agent, but they thought that they probably had a bacterial etiology of their pneumonia. And then there is this much bigger study, which was published in New England Journal of Medicine back in 2015. And they had close to 2,500 patients enrolled. Most of the patients had radiographic evidence of pneumonia, and most of those patients also had specimens available for testing. So what they found out is that some sort of a pathogen was identified only in 38% of the cases. Most commonly, viruses were isolated, as you will see in the picture on the next slide. And the most common bacterial pathogen, again, was strep pneumo. And I think the easiest is to look at the pie table. So again, pay attention that no pathogens were detected in 62% of the patient. And then viral pathogens were detected in 22% of the patients, with bacterial pathogens detected only in 11% of the patients. So when the guidelines talk about how to approach the diagnosis and management of pneumonia, they mention these two major principles all the time, that when you have a patient with community-acquired pneumonia, you have to make two determinations. Number one, are you dealing with severe versus non-severe pneumonia? And number two, if your patient has risk factors that put him at risk for MRSA or Pseudomonas. So if you look at the table on the right, that lists the criteria for severe CAP. So basically, you have to meet either one of the major criteria, which is number one, septic shock with the needs of pressors and or respiratory failure requiring mechanical ventilation. Or you have to have 3 or more of the minor criteria, which listed up on the top. So it's various clinical signs such as tachypnea, hypotension, confusion, and all of the other ones that you can see in the table. So based on the research and literature, these are the strongest risk factors that are associated with MRSA or Pseudomonas CAP. The first one is the prior isolation of MRSA or Pseudomonas, particularly in respiratory samples. Number 2 is a recent hospitalization in the past 90 days. And number 3 is exposure to parenteral antibiotics in the last 90 days. And then they also repetitively mentioned that clinicians should be aware of some epidemiologic risk factors for MRSA and Pseudomonas specifically related to your hospital or your patient population. There has been a lot of discussion in the literature and research going on about the usefulness of MRSA nasal testing in the hospitalized patients, specifically the use of this tool for antibiotic stewardship as a tool to rule out MRSA pneumonia and how helpful it is. I will show you some data later basically saying if you have a negative MRSA nasal testing, MRSA coverage can be generally withheld, especially if you're dealing with non-severe pneumonia. And this is a MRSA nasal screen meta-analysis, which was published in Clinical Infectious Disease Journal back in 2018. The objective of that study was to evaluate the diagnostic value of MRSA nasal screen, specifically for ruling out MRSA pneumonia. They included 22 studies and more than 5,000 patients were involved. Based on their numbers, the pooled overall prevalence of MRSA pneumonia was about 10%, and pooled prevalence of ventilator-associated pneumonia was 8%. So there are two numbers that I want you guys to be aware of. So as you can see in this table where I listed sensitivity, specificity, PPV, and negative predictive value for various subsets, you can see that negative predictive value for community-acquired pneumonia and formerly HCAP, it's actually very high. It's 98.1%. So basically what it means, if you have a negative MRSA screen, the chance of your patient having MRSA pneumonia, it's relatively low. What is important to remember that in patients with specifically ventilator-associated pneumonia, the sensitivity of MRSA nasal screen was pretty low, 40%. The conclusion that they made is that there is a low utility of using MRSA nasal screen in ruling out VAP MRSA pneumonia. And there have been several speculations, but one of them is that possibly the artificial airways, such as an endotracheal tube or tracheostomy, can serve as an additional source of MRSA carriage, not necessarily the nares. And remember, there are some patient populations where your MRSA testing by PCR, nasal PCR could be suboptimal. So these are the patients with recent nasal decolonization, patients with recent MRSA infection within the past 30 days. Interestingly enough, the literature says that patients with structural lung defects, such as bronchiectasis and CF, might have falsely negative MRSA, even though their lower respiratory tract can be colonized with MRSA. So I thought that was interesting and something to keep in mind for sure. So now we're going to start talking about the first portion of the guidelines that addresses specifics on the diagnosis of community-acquired pneumonia. And specifically, I wanted to discuss their recommendations on obtaining pre-treatment respiratory culture and the gram stain in patients with community-acquired pneumonia. The prior literature showed that in patients, especially in the outpatient settings and in patients with non-severe pneumonia, basically whether you pursue microbiologic diagnosis or not does not change outcomes. Based on that, the panel made recommendations to pursue sputum culture analysis in patients with severe CAP and patients that are at risk for MRSA Pseudomonas. As we already discussed, those are the patients that had infections with those pathogens in the past, or they were hospitalized or treated with IV antibiotics in the past 90 days. Also, patients that are that have severe pneumonia requiring intubation should undergo lower respiratory tract suctioning for sputum as soon as possible after they intubated. So specifically for the blood cultures, the recommendations are actually pretty similar. The recommendations are not to obtain blood cultures specifically for outpatients. And again, they even say for inpatients with non-severe pneumonia, it's not routinely recommended, but clinical judgment can be used. And the reasoning behind that is the yield of obtaining having a positive blood culture, it's actually relatively low. In terms of recommendations for obtaining urinary antigens, again, that is recommended to pursue only in adults with severe community-acquired pneumonia, or in the patients that have recent history of travel, or if you suspect that they were exposed to the source of Legionella, or there is a Legionella outbreak going on. It is recommended to obtain influenza testing during periods of high influenza activity. And recommendations for obtaining procalcitonin is a very gray zone. Throughout the document, it states that you can use it to perhaps guide your recommendations for how long you would like to continue antibiotic therapy and how the patients are improving. But it is not recommended to obtain it to determine the need for initiation of antimicrobial therapy. Basically, if you, even in the settings of a negative procalcitonin, if you made a diagnosis of community-acquired pneumonia, patients should be treated. So once you made a diagnosis of community-acquired pneumonia, the next question comes up: if this patient can be treated in the outpatient settings, whether or not this patient needs to be admitted. And the guidelines do recommend using validated clinical prediction rules along with your clinical judgment. So I think most of us are familiar with this validated clinical prediction rules that has been around for a while. The first one is called CURB 65. It's very simple. Pneumonia Severity Index is more cumbersome. I'll show you the table with that. However, the second one, the PSI, has been shown to identify large proportions of patients that are actually at lower risk and can be safely treated as an outpatient. So this is the curve 65, and as it implies itself, it stands for confusion, urea elevation, tachypnea or increased respiratory rate, blood pressure abnormalities, or age more than 65. And this is a Pneumonia Severity Index, which I think personally for myself it's very hard to remember. So when I had to use it a couple of times, I actually used MD-Calc, and I'm sure you can use other calculators that are extremely useful in that regard. So it is recommended that patients that have more or equal index of 3 on Pneumonia Severity Index are admitted to medical floor, and the patients that meet definition for severe CAP are admitted to ICU. And now we're going to switch the gears and we're going to talk about the treatment. So the first portion would cover the treatment of community-acquired pneumonia in the outpatient settings. And when you have a patient with a CAP in the outpatient settings, you have to make a determination how you treat it, whether it's appropriate to use very simple regimens as outlined on the left, or you have to pursue more comprehensive regimen. And the guidelines state that in the patients that have no significant comorbidities or risk factors for Pseudomonas or MRSA, you can use one of the following regimens: amoxicillin 1 gram TID, doxycycline 100 milligram BID, or macrolide as listed below. In the patients with comorbidities, and I will show you the list of the comorbidities in the following slides. In the patients with comorbidities, it is recommended that you use either a combination of amoxicillin clavulanate or cephalosporin combined either with macrolide or doxycycline. Also, they list respiratory fluoroquinolone is an appropriate option for the standard regimen. Specifically for amoxicillin/clavulanate, I'll mention that they actually mentioned 3 different dosing, either 500 milligrams of amoxicillin 3 times a day or 875 milligrams twice a day. And they also mention an extended release formulation, which is 2,000 milligrams twice a day. So that would be an appropriate dosing for the augmentin specifically. And this is just a table how it comes up in the guidelines, if in case anybody likes to look at this way. So what the study showed in the past that in the patients without comorbidities, they did not observe any significant difference in outcomes between any of the compared regimens. And this is the meta-analysis, which was published in 2008. It included 13 eligible studies, and they had more than 4,000 patients with a diagnosis of outpatient CAP. And if you look below, you can see that some of the studies studied macrolide and fluoroquinolones. There were 3 studies that studied macrolide and beta-lactam, 3 studies that studied fluoroquinolone and beta-lactam, and 2 studies that studied cephalosporins and beta-lactam / beta-lactamase inhibitors. The conclusion was that there was no significant difference regarding of clinical success and mortality, regardless of atypical coverage. So we're talking about the outpatients without significant comorbidities. And this is the comorbidity list that we should be aware of. And again, if you have a patient that has one or more of the following, again, that would be indication to start treatment with a more comprehensive regimen. So I thought it was an important point to mention that despite the black box warning that was issued on the use of fluoroquinolones, the guidelines, the panel felt that fluoroquinolone monotherapy was still an appropriate standard regimen option in the patients with community-acquired pneumonia with comorbidities. And the reasoning behind that is that we have a lot of data saying that they're extremely effective in that particular population, number one. Number two, they have excellent oral bioavailability, and the discontinuation rate was actually very low because they are dosed once a day. So now we're going to switch gears and talk about the treatment of community-acquired pneumonia for hospitalized patients that are admitted with non-severe pneumonia. So we're talking about the patients that are admitted to the general medical floor, let's say. For those patients, the standard regimens that are recommended would be, number one, either a combination of beta-lactam plus macrolide or a fluoroquinolone monotherapy. The next step that we should do is to assess patients' risk factors for MRSA or pseudomonal infections. As you can see on the top portions, what it tells us that if you have a patient who has been admitted for community-acquired pneumonia and you have an evidence of prior respiratory isolation of MRSA or Pseudomonas, most of those patients should receive MRSA or Pseudomonas coverage until you have culture results available. On the other hand, if you look at the bottom portion, so what it tells us, if you have other risk factors such as recent hospitalization or IV antibiotic use within the 90 days, the recommendations are to obtain cultures and the MRSA nasal swab, but generally the MRSA and Pseudomonas coverage can be withheld in this patient population unless culture results are telling you otherwise.
So, so going back, so I feel like in practice, we don't typically, there's very few, as ID stewards, I guess, we typically look at the clinical picture before starting Vanco, even though they're MRSA colonized, when they come in with a CAP picture. I feel like it's not consistent in how we do it right now, but you're saying that essentially empiric coverage, if someone coming in with MRSA colonization and evidence of community-acquired pneumonia, they need it up front. Because I feel like it's, even though the MRSA colonization's there, we still see the ceftriaxone as a throw, and because the patient's not severely sick.
So, if the patient is has non-severe pneumonia, and let's say test positive for MRSA by nasal swab, the general recommendations would be to start the treatment until the culture results become available. Yeah. So these are just the options that we are able to use in the standard regimen options, specifically for the combination of beta-lactam plus macrolide. So as you are beta-lactam, you have an option to use unicin, cefotaxime, ceftriaxone, ceftaroline, plus for the macrolide you would use either azithromycin or clarithromycin. Or as we already mentioned, respiratory fluoroquinolone can be still used as a monotherapy in hospitalized patients admitted with non-severe pneumonia. So the alternative regimen mentions the combination of beta-lactam plus doxycycline. However, make a note that this is not in the standard regimens because we just do not have as many studies telling us that it performs the same way. If we determine that the patient does require MRSA coverage, for those patients based on a recent HAP/VAP guidelines, we would go ahead and add either vancomycin or linezolid. I actually felt it was very interesting that ceftaroline was not included in here. And for Pseudomonas coverage, we would modify our standard regimen to include Pseudomonas coverage with one of the following. So you have an option of piptazo, cefepime, ceftazidime, imipenem, meropenem, or aztreonam, specifically in penicillin patients with severe allergies. So a couple of slides specifically on the use of beta-lactam monotherapy in hospitalized patients. So I will show you some data, but the consensus is that beta-lactam monotherapy is not recommended for the treatment of community-acquired pneumonia in inpatient settings based on the prior literature and studies. So this was a systematic review which was published in JAMA back in 2016 on antibiotic therapy for adults hospitalized with community-acquired pneumonia. And they had 3 objectives for this study. They studied the optimal time to antibiotic initiation. Number 2 was the optimal initial antibiotic selection. And number 2, what are the criteria for transitioning IV to oral therapy? There was 20 studies that met eligibility criteria for this systematic review. Specifically, what they discovered on the question of which antibiotic selection was the best. So this is a very busy table, but I want you to pay attention to the table on the right, and specifically to this one study by Postma, which was published in 2015. It's also known as a Danish study, and that was the study that actually showed non-inferiority of beta lactam use as a monotherapy. However, there were some questions about the design of the study, so the panelists were not very confident, perhaps how strong results of that study were. Therefore, recommendations were to advise against beta-lactam monotherapy in hospitalized patients. And now we're going to move to discuss the treatment of severe pneumonia, and I just wanted to show you guys this table one more time. What do we define as a severe CAP? So remember, either you have to have one major criteria, or you have to have 3 or more minor criteria from the top of the table. So for this patient population, they recommend to use combination therapy in any standard regimens. So for standard regimens, they list number 1, the combination of beta-lactam plus macrolide or beta-lactam plus fluoroquinolone. Notice that the fluoroquinolone monotherapy is no longer here as an option, right? So we're talking about severe pneumonia. The second step, as we would do with any patients admitted for community-acquired pneumonia, we would assess the risk factors for MRSA and Pseudomonas, right? So I put a circle over it, but notice that with this patient population, even if you have risk factors such as recent hospitalization, recent IV parenteral antibiotic use within 90 days, the recommendations are to initiate coverage for MRSA and Pseudomonas while you're awaiting results. So maybe that would be a scenario that, you know, we would just go ahead and start the coverage as well. And that was different from patients that are admitted with non-severe pneumonia that you can actually hold off on in the lower two graphs. So this slide just mentions the antibiotic combination that we can use in such patients. So for standard regimen options, as I said, it's either a combination of beta-lactam plus macrolide or a combination of beta-lactam, as mentioned above, plus fluoroquinolone. This is the same slide with options for MRSA and Pseudomonal coverage if needed. So you guys saw this before. And I wanted to show you some data indicating that it has been shown that macrolide-containing regimens are better than non-macrolide regimens for the treatment of severe community-acquired pneumonia. And these are the recommendations, current recommendations. So this was a systematic review and meta-analysis, which was published back in 2014, that included 28 observational studies. It was actually a pretty large study that included almost 10,000 of critically ill patients with community-acquired pneumonia. What was seen in this study is that macrolide-containing regimens were associated with significant mortality reduction comparing to other regimens. And here is another study which was published in Clinical Microbiology and Infection back in 2017. Again, this was a systematic review of 17 observational studies. The objective of this study was to study a best treatment option for hospitalized patients with community-acquired pneumonia by looking at all-cause mortality. Interestingly, they also specifically looked at the combination of beta-lactam / macrolide versus beta-lactam / fluoroquinolone. And the conclusion of this study was that there was a trend toward higher mortality with beta-lactam / fluoroquinolone combination comparing to beta-lactam / macrolide combination. And this is just a graph from that article, and you can see that there is a trend toward higher mortality with beta-lactam fluoroquinolone combination, and as you can see going on the right. They commented that it was a very low quality evidence, so more studies needed to confirm it, but that was the conclusion from this study. Questions came up how we can explain the macrolide effects and why it appears that they influence mortality in a good way. I think we do not know the answer exactly, but likely that macrolides possess some immunomodulation properties, and by doing that, they might contribute to better patient outcomes. There was also a speculation whether patients that receive beta-lactam / fluoroquinolone combination potentially select for multi-drug resistant organisms. However, that was not demonstrated in the study, so that's like unproven theory. And just one slide on the antibiotic duration in patients with community-acquired pneumonia. The consensus is that 5 days of therapy should be enough for most patients that are treated in the outpatient settings. For hospitalized patients with non-severe pneumonia and that are actively improving, 5 to 7 days of therapy should be appropriate. Specifically for MRSA and Pseudomonas pneumonia, they state 7 days, which would be in consensus with the recent HAP-VAP guidelines. Also, some exceptions that we all should be aware of. Let's say if we're dealing with pneumonia that is associated with the deep-seated infections such as meningitis, endocarditis, or let's say Staph aureus bacteremia, remember that sometimes the duration of therapy would also depend on the other diagnosis. Therefore, we have to make sure we account for the overall picture and not necessarily stick to the 7-day number. Longer duration of therapy, most of the times needed for unusual pathogens such as mycobacterial tuberculosis infection, endemic fungi, and some other pathogens. So that's what I already mentioned. For MRSA and Pseudomonas pneumonia, 7 days of therapy should be sufficient in the cases of uncomplicated clinical course, which is in agreement with HAP guidelines. However, longer duration might be recommended for complicated pneumonia, specifically the pneumonia which is associated with pneumonic effusion, empyema, or a lung abscess. So what do guidelines say on the treatment of influenza? Again, a lot of literature is coming out on influenza specifically, but it has been a known fact that a lot of patients would have a bacterial co-infection either from the very beginning, or bacterial infection joins in the course of influenza treatment. The autopsy studies showed that patients that actually passed away from influenza had an evidence of bacterial co-infection in up to 30% of the cases, so it's extremely common. The recommendations are to start anti-influenza treatment independent of duration of illness if the patient tested positive for influenza. And it's very important as well that in the patients with positive influenza that by definition meet criteria for CAP, they should be started on a CAP coverage as well. And that at 48-72 hours, you can make a determination if antibiotic therapy may be discontinued versus complete both influenza treatment and antibiotic therapy. There was one small paragraph that covered aspiration. If you suspect aspiration pneumonia as the etiology of your community-acquired pneumonia. On that topic, there was actually a nice review that was published in New England Journal of Medicine, if you guys are interested in reading it later. But basically, the consensus is that anaerobes might not be as common in the etiology of aspiration pneumonia as we used to think about it. Therefore, anaerobic coverage is not routinely recommended unless you suspect a community-acquired pneumonia with empyema or a lung abscess. Based on the guidelines, steroid therapy is not routinely recommended unless you have a patient with refractory septic shock. And just to wrap things up, despite all of these concerns about multi-drug resistant organisms being on the rise, remember that most of the outpatients with community-acquired pneumonia can be safely treated with a very basic antibiotic regimens. And even if you go into inpatient settings, remember risk stratification is very important. But if you have a patient without significant risk factors, as we went over with, again, that patient should be able to receive your standard antibiotic regimens. We all need to be aware of MRSA and Pseudomonas risk factors in our patient population. And they also make an emphasis that these days we need to be aware of specific epidemiologic risk factors for MRSA and Pseudomonas where you practice, right? So let's say specifically for Moffitt or VA or for your city, things like that. And of course, more research needed to answer some key clinical questions or provide stronger recommendations for the questions that we discussed. And I'll be able to take questions. Thank you.